Hello, welcome. I'm Yvonne Vigar and I will give you an update on the Somerset bid to the Patient Voice programme. Our project is known as the Wellbeing Volunteers Project, and we are implementing personalised care planning in the form of My Life Plan. In August 2014, Somerset CCG placed a bid to the Patient Voice team for funding to support the implementation of personalised care planning, which we have called locally My Life Plan, using wellbeing volunteers in secondary care. The personalised care planning process was based on the House of Care model, which was already being rolled out by GP practices in Somerset, but it was felt that by introducing this model in secondary care also, it provided an opportunity to more effectively support the discharge of patients and address more patients. It was also felt that there would be benefits in using volunteers to support people with their personalised care planning. Patients would have access to personalised care planning at an earlier stage. The emphasis of their care planning would be focused around their social needs and based on their own individual circumstances rather than being clinically led. Volunteers could signpost patients to other support services, and being at the point of discharge, it would mean that patients access these services at an earlier stage. And using voluntary sector agencies would mean that we could address health inequalities better. Somerset CCG were successful in securing funding in order to set up the programme. This would require a project team to be developed involving multiple stakeholders. It would require volunteers to be identified and be trained in the delivery of personalised care planning. It would require a pathway to be developed and governance structures to be implemented, identification of appropriate patients, and for the personalised care planning process to be trialled using patients with heart failure, along with 2 other long-term conditions, before being considered for rollout to other specialties. The House of Care model nicely sums up these processes in the form of a house, with the person-centered care happening in the middle, and with the building blocks to make it happen around the edges, these including the organisation and clinical processes, partnership working of health and care professionals, informed individuals and carers, and commissioning processes. It is in implementing these structures to support personalised care planning that we have learnt a lot about the strengths and weaknesses of the project, and I'll take you through each of these in turn. So first of all, person-centered care, and as I said before, we have called this locally My Life Plan. So in implementing person-centered care, we looked at using the House of Care personalised care plan. Personalised care plans are a proven tool, and so in this respect was a lot easier to consider for implementation, as we did not need to go through extra governance approval. We were also already implementing the personalised care planning tool in primary care, with us asking GP practices to use the House of Care model in addition to the avoiding hospital admissions directed enhanced service requirements. Therefore, being able to extend the use of an existing tool was much more efficient than developing some new. However, what we have found is that the needs of personalised care planning is evolving, and this has resulted in multiple changes and tweaks to the care planning tool. We are currently on version 32, and it is likely to change further in the future. Therefore, version control is really important. In terms of organisational and clinical processes, I think it's clear that the project is complex, involving multiple stakeholders, including the CCG, the CSU, secondary care, GP practices, the voluntary sector including Age UK, British Heart Foundation, Diabetes UK, Alzheimer's Society and Somerset Site. It was quite obvious from the outset that in order for the project to work that we needed a strong commitment from all involved, and that this project was worth taking forward. So we spoke to the key people from each organisation, so the Deputy Chief Executive from Taunton and Somerset NHS Trust, the Chief Executive from Age UK, and regional managers from other voluntary agencies. Since there was a really strong willingness from these organisations to be involved, it meant that their delegated officers had commitment right from the start, and this has enabled change to happen for us. As well as having strong managerial leadership, we realised that it was imperative to have strong clinical leadership. We therefore involved the consultants in coronary care disease early on to discuss the project and to gain their views on the pathway. Their engagement has enabled us to not only develop a very practical clinical pathway, but has also ensured that the whole department is signed up to the delivery of the pathway. One of the biggest challenges to the project has been the time spent in developing the governance and infrastructures to ensure that the processes can run safely and smoothly. This is largely because we have volunteers belonging to multiple voluntary agencies working with patients from secondary care. We therefore had to agree early on that we could not have multiple governance systems in place. This would lead to multiple and unsafe practices. We were fortunate that we were able to agree that Age UK would take responsibility for all of the governance of the project, with Age UK being responsible for all the volunteers, regardless of what voluntary agency they came from. They would provide management and coordination of volunteers, working to an agreed volunteer protocol for which training would be given. So this would mean that all volunteers would have to undertake an induction with Age UK, but it was also agreed that for health and safety and confidentiality reasons, volunteers would also be required to undertake a short induction with Taunton and Somerset NHS Trust to ensure familiarity with TNS procedures. This has simplified the governance processes enormously, but it did take quite a lot of time to get there. It first of all involved agreement by all parties, review of procedures, and then an agreement to be drawn up between Somerset CCG and Age UK. And this was actually delayed further because the chief executive from Age UK retired during that time, which meant that although the organisation supported the concept of the project, discussions had to start again to enable the new chief exec to gain the full understanding of the project and to be able to commit to taking on the governance. All of these things weren't foreseen at the outset. Part of the governance procedures has included a boundaries document for volunteers. The project group were keen to ensure that volunteers did not act outside of their role, particularly in offering any kind of advice, and particularly clinical advice to patients. Therefore, a document has been developed which outlines these responsibilities and boundaries really clearly so that volunteers know they are providing motivational interviewing and can offer signposting, but do not recommend activities and actions for the patient. This is viewed as really important for protecting the volunteer, the patients, and has ensured that health professionals do not feel that the My Life plan compromises the clinical health plan for patients. IT, as usual, has also been a challenge, and we have looked at various solutions. Unfortunately, there has not been a simple solution where the care and support plan information can be uploaded into the patient record system and shared with all approved practitioners from different organisations. We are working towards this, but initially we're having to work around it. So completed personalised care plans are being copied, the original given to the person and the other being used to key data into a template, and then this is being attached to an email and sent securely to the GP practice and other appropriate and agreed practitioners. GP practices will then load the details through an EMIS web input template onto the person's record. We have limited the pilot initially to the Taunton area in order to reduce the communications and the processing problems. People are signing the standard Somerset House of Care data sharing agreement and are identifying the organisations that they do not want to share their data with as well. The next part of the house is health and care professionals committed to partnership working. As previously said, early engagement from the organisations involved has been critical. By having the senior leadership teams of organisations committed, this has filtered through to the operational support for the project. This has resulted in a really strong project team involving all organisations and who are strongly engaged and committed to the outcomes. It is also very clear that there is a real willingness to work together and find workable solutions. The previous example of the governance infrastructure is just one, but clearly by all organisations wanting it to work, they were able to sign up to a pragmatic solution which enabled governance processes to be in place, but did not rely solely on their own organisation's processes. This willingness to make things work is paramount and will determine the success of the project. In implementing the project, we have and are continuing to make new discoveries regarding other similar or related projects all the time. We therefore feel it is essential that we map out these projects so that we can work with them rather than against these projects. If we are to make this project sustainable, we need to work within existing infrastructures. This will make better use of resources and will mean that we can learn from what works well in each project and create something better. A key link has been made with other voluntary schemes at Taunton and Somerset NHS Trust. This has enabled us to learn from their systems in terms of recruitment, retention and governance. We're also keen to give existing volunteers the opportunity to be involved in this project so that we have a strong group of volunteers engaged with the programme, which we believe is key to making it sustainable. One of the areas that we had not considered is that there are some stakeholders for whom it is not in their interest to be involved in the project. This has become apparent in the area of parking. As a group, we were keen to offer free car parking on the hospital site to make it easier for volunteers to be involved and to reduce the costs of the project. Parking at Taunton Somerset Hospital is £10 for over 4 hours of parking. We were aware that the car parking company that runs the car park at Taunton and Somerset NHS Trust had issued a small number of permits to other voluntary projects. However, it is apparent that the number they have issued falls well short of the number of actual volunteers, and that it was unlikely that any requests for more parking spaces would be met, since the parking company is an independent business and any permits given results in less profits for them. Therefore, despite having a really cohesive project team, we cannot conquer everything. That said, we are now recommending the use of park and ride for volunteers, so we have found a solution. Next part of the house is engaged and informed individuals and carers. It is really important that this project doesn't just focus on the practicalities of implementing, but ensures that it is what patients and carers want and need, and proactively empowers patients and carers. We have therefore included a patient representative on the project group, which has been instrumental in ensuring that the pathway is logical and has as few steps as possible to make it easy for patients. It has also ensured that communications are easily understandable in plain English and without the use of medical jargon. In addition, we have used the Somerset House of Care Patient Wizard Group, a representative group of patients, carers and the voluntary sector set up to support personalised care planning as a whole, so not just the Wellbeing Volunteers project, to review communications and give their views. This means that patients and user experience is integral to the setup of the project. Furthermore, we are committed to ensuring that any feedback from patients and carers is taken into account during the review process. We are using patient and carer evaluations, and these will directly inform the rollout of the service. Each patient is being asked to complete the first 13-step patient activation measure known as the PAM, which will identify how activated they are and help clinicians and other practitioners to determine the level and type of support that they need to better manage their condition and life. They will be asked to complete another PAM in a few months' time to see whether the services provided have made a difference to their quality of life. The final arm is commissioning. In order for the project to become sustainable, funding does need to be secured for ongoing costs associated with this project. This is primarily the role of the coordinator, as well as any training or volunteer expenses. Whilst the costs are relatively low, it does need to be self-funded, and so changes to commissioning services will need to be necessary. We therefore need to demonstrate that the project not only delivers benefits for patients, carers and clinicians, but also has tangible benefits such as reduced GP attendances, hospital attendances, hospital length of stay and readmissions, both in secondary care and community care. So this would mean that less activity could be commissioned in secondary and community care and funding released for the rollout of the project. This means that systems for evaluating the project are absolutely key to the sustainability of the programme. Therefore, much time has been spent understanding what these systems look like and how we could demonstrate these tangible benefits as well as patient quality of life benefits. A key challenge to this is that the project itself is only 6 months, and in reality reductions in hospital activity are likely to be sometime after that intervention, and so the evidence is going to be available later than the commitment needed to roll out the project. Furthermore, the timescales of the project is outside the commissioning window, and so the project team are in a position where they have to make a case now for further funding in the absence of evidence. We know that this is a long shot, but funding the project to allow rollout is absolutely critical to gain any long-term benefit. So in terms of our overall learning, there have been lots of successes with the project. Gaining early engagement was absolutely key to the success, and getting the support from the top of organisations is a big recommendation. One of the biggest learnings was just how complex the project was. The involvement of so many agencies made it even simple things like getting a meeting organised very difficult, and the governance was very complicated. We therefore made a conscious effort not to be drawn into the problems, but quickly identified a solution to simplify the governance by having an overarching organisation responsible. Even by doing this, it took time, and far more time than we had allowed in the original project plan. So this is a big learning for anyone wanting to take on something similar. You really need to allow enough time for the infrastructure, as the whole project can fall apart without it. With a project like this, we can't move mountains, so we have kept the IT simple and are leaving the Somerset House of Care programme to establish a care and support planning solution across Somerset. Having multi-agency partnerships is complex. It does mean that lots of organisations want a say and lots of hoops need to be jumped through. However, when all the organisations are working towards a common goal, it is rewarding. Our group are really enthusiastic about the cause and are committed to making it work, and therefore we really pull together to find solutions. We also know that together we can use our resources more effectively, and so it's far more likely to be sustainable in the long term. Consequently, we are all positive about the project and hold the belief that this will work, not just in the project phase, but in the long term, to make real positive change for patients.